All right. Can you hear me? Okay. Yes. Thank you so much. I will be talking this afternoon on advances in the treatment of gynecologic cancers. I hope everyone can hear me in the back. Here are my financial disclosures. So, historically, concurrent platinum-based radiation plus chemotherapy for solid tumors has really been the standard of care. And this has been the standard of care for patients with locally advanced cervical cancer for now over 20 years, ever since the National Cancer Institute in the U.S. issued an alert in 1999 based on multiple randomized studies that showed a survival benefit to the addition of platinum-based chemotherapy to radiation. And it was based on these landmark 5 chemoradiation clinical trials. But, can we do better? And over the last 2 decades, we've investigated multiple agents, either concurrent with radiation or adjuvant to chemoradiation, including amifostine, COX-2 inhibitors, epogen, vascular endothelial growth factors, triapine, which is a study that's ongoing, and gemcitabine in addition to cisplatin. But to date, most of these studies have been negative. However, this study, published now over a decade ago in the Journal of Clinical Oncology, tested the addition of cisplatin concurrent with chemoradiation, as well as cisplatin and gemcitabine after chemoradiation. And this was a large phase 3 multinational randomized study. And it did show an overall survival benefit to the addition of cisplatin, or the addition of gemcitabine to cisplatin. But the study was complicated in that it was really testing 2 questions. Can we improve survival with the addition of gemcitabine concurrent to chemoradiation, cisplatin radiation? And does cisplatin and gemcitabine after chemoradiation improve survival? And so, although this did improve overall progression-free survival and actually overall survival, it's hard to tell, where the benefit came from. And this did come at some serious grade 3 and 4 toxicities and increased hospitalizations. So this is a very toxic combination. And so Lauren Bell at the University of California, San Diego, was interested in looking at whether we could use IMRT specifically to make this combination more tolerable. And as radiation oncologists, of course, we know that we're very interested in widening the therapeutic ratio. That is, moving the red normal tissue complication probability curve to the right and the local control probability curve, to the left. And this can be done by giving radiation sensitizers or decreasing the volume of radiation through IMRT or other more focused radiation techniques. But what I wanted to talk about today was kind of 3 main methods to augment the radiation response. And that is 1, potentially enhancing the immune system, 2, disrupting cellular signaling pathways, and 3, by blocking DNA damage response mechanisms. So we teach our residents and we tell our patients that radiation is a local treatment, right? We don't expect them to get hair loss if we're treating the pelvis. And we also tell them, that metastatic disease, is incurable. And this is what we've been teaching our residents and telling our patients for decades. However, the advent of immunotherapy has really flipped these paradigms on its head. And Tim Chan, gave a really elegant talk in the last session about immunotherapy and how it's really revolutionized the care of our patients. I was previously at the University of Pennsylvania, where one of my colleagues, a radiation oncologist who runs a laboratory, Andy Min, was very interested in testing whether or not radiation could, combined with checkpoint inhibitors, could reinvigorate exhausted T cells. And they did this in the laboratory in this pivotal Nature paper. Oops. I don't know what I hit. Oh, I don't know how to get rid of it. Oh, okay, thank you. Maybe I'll just stick with this. is in this pivotal Nature paper, what they did was they took mouse melanoma lines and injected them into both hind legs of mice, and then irradiated one hind leg while not irradiating the other, and giving them either an anti-CTLA-4, an anti-PD-1, or just radiation alone. And what they found was that the mice that received dual checkpoint inhibitor, that is an anti-CTLA-4 and an anti-PD-1, had better overall survival than the mice that received either radiation alone, vehicle, or single checkpoint inhibitor. So, and I wanted to kind of just briefly review, how radiation and immunotherapy may combine to enhance its therapeutic effects. So, as we know with radiation, or with large doses of radiation, these high doses per fraction, just a couple of fractions, it causes an antigen burst. And these antigens are then picked up by antigen-presenting cells or dendritic cells that then present them to T cells and result in these activated T cells. However, and then these T cells then expand and go to both the primary lesion, but perhaps also circulate to other lesions within the body. We know that this is much more complex and that the immune system is also revving up these regulatory T cells that will come in and tamp down the response. And so this is where the checkpoint inhibitors come in to prevent oops, I think I did this wrong, this decrease in response. And so we were very interested in taking Andy Min's observations into the clinic, and we conducted a phase 1 study of durvalumab, tremelimumab, and hypofractionated radiotherapy in patients with metastatic cervix, vulvar, and vaginal cancers. And since I had moved to MD Anderson from Penn, we opened it at MD Anderson and the UT Southwestern Hospital in Dallas. And so this is the schema for the study. And so durvalumab is an anti-PD-L1 and tremelimumab is an anti-CTLA-4. And so we gave 4 cycles of the dual checkpoint inhibitor, followed by 4 cycles of durvalumab alone, so a total of 8 cycles of immunotherapy, and 3 fractions of SPRT. So the SPRT was during week 2. We also had obtained a number of biospecimens as well, blood, tumor tissue, as well as cervical and rectal swabs, which I won't present that data today here. But we enrolled 18 patients in that study, and the majority of them had cervical cancer. None of the patients had vulvar cancer, and all of them had to have had at least one prior line of systemic therapy for their metastatic or recurrent disease. And the majority, 3/4, had prior radiation, either pelvic or extended field radiation. About 2/3 of the women had high PD-L1 tumors, and the majority had squamous cell carcinoma. So overall, the regimen was very well tolerated within the group. We did have 2 immune-related adverse events. One was a patient that had hypothyroidism, and the other was a patient that had conjunctivitis or dermatitis. She required hospitalization and steroids, but we were able to resume her checkpoint inhibitor. There was no treatment-related discontinuation of therapy, and about half the patients had a grade 3 or 4 adverse toxicity. So overall, this is our response data. We had 3 objective responses, so 1 partial response and 2 complete responses. And this graph on the right here, the swimmer's plot, separates the patients by their PD-L1 status, high versus low, and then their overall response. And the arrows represent the lines represent their time on treatment, time since the start of their therapy. X's represent that they are deceased. The little triangles here represent that they're still alive and being followed. And the little bars, the solid bars, represent the amount of time that they were actually receiving active therapy. So the patient up on top received the full course of therapy. And some of the other patients progressed and the therapy was stopped. So if we look by response by PD-L1 status, the patients that had objective responses all had PD-L1 high tumors. But if we look overall at those patients that had clinical benefit, there were patients that had clinical benefit with low PD-L1 tumors. And then if we look by response by prior pelvic radiation, the patients that had complete responses were in patients that had prior radiation. The patient with no prior radiation, partial response had no prior radiation. However, we did observe clinical benefit in patients that had no prior radiation compared to those that had prior radiation. But as Tim had suggested in his last talk, there are very few, or the actual observance of a abscopal effect is very rare. And I cannot say that this patient definitively had an abscopal effect, because it's possible that without the radiation, she still also would have had this a complete response. But this red arrow denotes the lesion that we treated with SBRT, 8 grade times 3, but she had multiple other liver lesions and peritoneal metastases. She was in her 30s. She initially was treated with a hysterectomy for her cervical cancer, and then subsequently developed a recurrence locally and received pelvic radiation and concurrent chemotherapy, and then developed peritoneal disease and received systemic therapy for that. So she had significant prior lines of therapy. But as you can see, by cycle 5, her disease had significantly regressed. This is her peritoneal disease at baseline, and then by cycle 5, there was very little disease left there. And she remains in CR without any evidence of disease, now almost 4 years out from her checkpoint inhibitor, and she hasn't received any therapy since completing her immune checkpoint inhibitors. And this is just a table of ongoing phase 1, 2, and 3 radiotherapy and immunotherapy trials in patients with solid tumors. So mainly endometrial, cervical cancer. I did want to highlight 2 important landmark studies that were presented at the Society of Gynecologic Oncology meeting just a few weeks ago in Tampa. I attended the meeting, but unfortunately had to leave before these 2 papers were presented in the plenary session. But the first one here is NYG018. It is a study of carboplatin paclitaxel plus or minus pembrolizumab for women with measurable stage 3 or 4A endometrial cancer or recurrent endometrial cancer, and they were randomized 1-to-1. They were stratified by MMR status. So I just wanted to highlight here that these patients had to have measurable disease. So even if they had stage 3 disease and had surgery, they had gross disease that was left behind. But overall, as you can see here, about 40% of the patients had prior radiation. But importantly, what they observed, as you can see here from the Kaplan-Meier curves, is that there was a significant difference in progression-free survival between those patients that received pembrolizumab versus placebo. And this important difference was observed both in patients that had MMR deficient and MMR proficient tumors. And the p-value was significant for both groups here. And these are just the adverse events, and overall, I think it was reasonably tolerated. So this was the other study that was presented at SGO in the same plenary session at the SGO meeting. This study, both of these papers came out on the same day of the presentations at SGO. Dostarlimab. So it was called the RUBY study. So this also enrolled patients with primary advanced stage 3 or 4 endometrial cancer or first recurrent endometrial cancer, and they were randomized 1-to-1, receiving carboplatin, paclitaxel, or placebo, or carboplatin, paclitaxel, and dostarlimab, and they could receive it up to 3 years. For the GY018, the pembrolizumab was given up to 14 cycles, so certainly this was given much longer. And they also stratified by MMR status. And so they outline here the group of women who had primary stage 3 or stage 4 disease versus recurrent. About 20% of the women had stage 3 disease here. And overall, about prior external beam radiotherapy, it was definitely less than the GY018 study, 15%. And so what they observed was they also observed a benefit to the group that received dostarlimab, a significant difference in overall survival. But an important difference in their study compared to GY018 is that they only observed the survival benefit in patients that had MMR deficient tumors. They did not observe the same benefit in patients that had proficient, MMR proficient tumors. So no doubt this will change our standard of care in the US, and it'll be interesting to see what our GYN oncologists prefer in terms of selecting pembrolizumab or dostarlimab. You know, pembrolizumab can certainly be given to a wider group of women because the MMR proficient women also benefited. So now I wanted to move on to discussing therapies that look to inhibit signaling pathways for tumor growth and hypoxia. So we are looking at a drug called nalfinavir. It is a protease inhibitor against the HIV-1 protease. It inhibits, it's been on the market for 20 plus years, so there's a lot of safety data on it. The biggest toxicity is diarrhea. But it's thought to inhibit the PI3 kinase AKT pathway. And then the other drug is a glutaminase inhibitor, which targets glucose metabolism that colleagues at Washington University are investigating. So nalfinavir, as I mentioned, is an HIV-1 protease inhibitor. And these studies were done by colleagues at the University of Pennsylvania that I used to work with. And what they showed was that in mice with head and neck squamous cell carcinomas implanted, that if they gave them control, nalfinavir alone, radiation alone, or the combination of radiation and nalfinavir, there was a greater delay in regrowth in the mice that had received radiation plus nalfinavir. And you can see that nalfinavir here in this sort of Western blot resulted in decreased phosphorylation of the AKT. And so based on these observations, we were very interested when I was at Penn in taking this drug into the clinic and testing it in patients. So we ran a number of clinical trials in non-small cell lung cancer. Colleagues ran studies in patients with glioblastoma multiforme, rectal cancer, pancreatic cancer. These were done abroad in the UK. And then I, together with one of my colleagues in GYN oncology, ran a study in patients with cervical cancer. But I just wanted to show the results because they were perhaps some of the most promising in patients with non-small cell lung cancer. So this study was conducted before the era of durvalumab. So these patients just received concurrent chemoradiation plus nalfinavir in a phase 1/2 study. And what was observed is that their median overall survival, I don't think I wrote it here. Oh, here it is. Median over, oh no, that's the other one. Median overall survival, I think, was like 47 months. So it was significantly higher than the best data just of concurrent chemoradiation at that time. And so this are the results of our phase 1 study of nalfinavir and chemoradiation in patients with locally advanced cervical cancer. And we performed the study in just 11 patients with a median follow-up of 50 months. And we had no in-field failures in this group of women, and just one patient who progressed, I believe was in the lung within a year of treatment. So I just want to talk a little bit about a glutaminase inhibitor, CB839. These studies were done by by colleagues, I think, at WashU. So CB839 was given concurrent with radiation alone or versus control or in a group of SIHA xenografts. So this is a cervical cancer line. And you can see that the best outcomes were observed in the mice that received the combination. And I know that they were very interested in taking this into the clinic as well. However, the company, I think, is perhaps not as enthusiastic about moving forward. The other group of drugs that I wanted to talk a little bit about was DNA damage response inhibitors, or DDR inhibitors. So we know that radiation works by increasing DNA damage and by inhibiting DNA repair. And perhaps by adding a DDR inhibitor, we can potentiate the response of the two together. And so there are a number of DDR inhibitors out in the clinic, right? We know that they're PARP inhibitors, but they're also ATR inhibitors, WEE1 inhibitors, DNA PK inhibitors that are being tested either alone or in combination with other systemic agents. And so PARP1, as you know, is a chromatin enzyme and repairs single-strand DNA breaks. ATR stabilizes the replication fork and is a G2M checkpoint regulator. WEE1 inhibits CDK2 in the S phase and CDK1 in G2M, and then DNA PK inhibitors block phosphorylation of key enzymes involved in DNA repair. And so these are just a table showing the PARP inhibitors that are in the clinic or under active clinical development. There's veliparib, which has no current FDA-approved indication yet, and then olaparib, rucaparib, niraparib, and talazoparib, who all have a FDA-approved indication. Pamiparib does not yet have any FDA indication yet. It's still in some limited early phase clinical trials. And so the thought about combining PARP inhibitors and radiation is that PARP inhibitors cause these increased DNA adducts, which stall the replication forks and prevent the repair of DNA damage. But we also know that the combination needs to be carefully utilized as well. But these were our early studies in mouse xenografts that published a couple of years ago in conjunction with colleagues at the University of Pennsylvania. So these were xenograft studies of olaparib and radiation. So we looked at mice that had an OVCAR F2, which is a BRCA1 wild type line, compared to OVCAR 8, which is a BRCA1 methylated or deficient line. And we observed that the addition of olaparib to radiation compared to radiation alone or olaparib alone had the greatest delay in regrowth, which is shown here by this purple line here and here. And this observation was made not just in the BRCA1 deficient lines, but also in the BRCA1 wild type, suggesting that if we brought PARP inhibitors into the clinic to test with radiation, the benefits would not be limited exclusively to patients that had defects in PARP1. And so that's what we were interested in doing. But just to show you that this was also being tested by other groups out there in multiple other cancers, these are the ongoing phase 1 or phase 2 studies of radiation and PARP inhibitors in triple-negative breast cancer or inflammatory breast cancer, pancreatic cancer, rectal, and head and neck cancer. But this was one that was tested in Europe, olaparib combined with high-dose radiation. What they observed was that they combined it with low-dose cisplatin too, which I think was probably too much for some of the patients. It was not tolerable due to esophageal and hematologic toxicity. And they really started at very low doses of 25 milligrams once a day of olaparib. And just to keep in mind, the The monotherapy dosing of olaparib, I believe, is 300 or 400 milligrams twice a day. So to start out with 25 milligrams once a day, which is the lowest dose or formulation that's available, you know, they were starting at a very low dose, but even with that, even without cisplatin, there was significant toxicity. And this may have been due to the fact that they were using hypofractionated doses, sometimes like up 2.5 or 3 gray, which probably was a bit higher than what was necessary. And so monotherapy is 300 milligrams. And so we were interested in testing PARP inhibitors combined with radiation in patients with gynecologic cancers, but we also knew that we needed to be very, very careful about the potential toxicities in women that had perhaps curable recurrent tumors. And so we opted to give the PARP inhibitors not daily, but we started out with, I think, twice a week, and then we've increased it to 3 times a week. And with talazoparib, the monotherapy dose is 1 milligram once a day, and we went down to 0.25 milligram dosing. So 25% of the dosing, and we started just with twice a week. And our top dose isn't going to be any higher than 3 times a week with radiation. But others are looking at combining ATR inhibitors and radiation, and here's the rationale here is that it inhibits the repair of DNA here at this site. And there are a number of ATR inhibitors. I don't believe any of them has an FDA indication yet, but AstraZeneca has a ATR inhibitor called AZD638, and then there's this Bayer 1895344, and EMD Serrano has one as well that are being tested. And there are a number of phase 1, phase 2 studies, and phase 3 studies looking at ATR combined with radiation for either locally advanced head and neck cancer or recurrent head and neck cancer or solid tumors refractory to conventional treatment in the palliative setting. And similarly, DNA PK inhibitors are being investigated as well for similar rationale, preventing DNA repair for a number of cancers as outlined here. So, I just wanted to kind of summarize here the agents in clinical trials with radiation. So there are a number of studies looking at immunotherapy plus radiation. And as Tim had mentioned, we don't know exactly the best combination for immunotherapy and radiation, whether we should be giving them concurrent, adjuvant or neoadjuvant. Now with a number of studies reporting out in head and neck and the CALA study in patients with cervical cancer, at least reporting out in an abstract form, concurrent probably is probably not the way to move forward, but perhaps neoadjuvant immunotherapy in the locally advanced setting maybe, or adjuvant. And we'll see, there are a number of clinical trials that haven't reported out yet. But we do want to improve on cisplatin and radiation for women with locally advanced cervical cancer or locally advanced vaginal or vulvar cancer. And so I think it's important to continue to investigate, either immunotherapy or these DDR inhibitors combined with radiation, or even these other cell signaling modulators that are out there. I think that's my last slide. Any questions?
Thank you for your presentation. I have a great interest to the chemoradiation combined with navir. Yeah, Navir. Yeah. The result looks promising, and there is phase 3 trials is conducting in India.
That's
but
right.
I don't have such experience about chemoradiation combined with Navir. So, could you please share some side effects? If there are any side effects?
Sure, yeah. I think that nelfinavir, the combination of nelfinavir and chemoradiation is quite promising, but the reality is that because nelfinavir is off patent, so it off patent in the United States, it means that there isn't a pathway forward for the pharmaceutical companies to generate revenue from a drug that has lost its patent. But I do think it's quite promising from the results that I showed you. The main toxicity is diarrhea. So these patients will get a lot, even when they're not getting chemoradiation, in patients with HIV getting nelfinavir, the main side effect was diarrhea. And this is why it's really no longer being used for HIV, because there are other new generation agents that are better tolerated. And so it's actually kind of hard to find nelfinavir in some markets. I don't even think it's made in Europe anymore. And so the group in India, and it's interesting that they couldn't find a pharma company in India to make it, but they actually have to source it from Canada, is what they've told me. And their study, I think, is still ongoing and accruing. So hopefully we'll see, promising results from their study. But diarrhea is the main side effect. And we never went above the FDA-approved dosing of nelfinavir. So it's the same dosing that's given for HIV patients. I believe it's 800. I'll have to look it up, but I can tell you later. Or it's in the paper what the dosing is. But it's the same dosing of nelfinavir.
And another question is some patients of cervical cancer, they have a central necrotic nodes. Yes, lymph nodes with central necrosis pattern. If you have any experience about the olaparib or some immunotherapy to these patients, for better response to the central necrotic lymph nodes.
I don't have any specific, it would be very anecdotal, but I can tell you, that patient whose scans I showed that had the complete response to checkpoint durvalumab and tremi on our study, she had, it wasn't a lymph node, but she had some fairly significant liver metastases and also peritoneal disease. And you can see here, I don't know that there was necessarily necrosis centrally for her, but I think, she still responded. So, but she did have PD-L1 positive tumor. And so my guess is that, as Tim had shown, that's an important.
Good response.
I think that's an important biomarker for response, like PD-L1.
Thank you.
But great, thank you for your questions. If no other questions, I'm happy to end a little early. Oh, you have one.
Thanks for your talk. I want to ask, do you have any comments of fraction size of radiotherapy with IO? For example, I may have patients cervical cancer with lung metastasis, and the patient will be treated with IO. So any fraction size is appropriate for this patient. Use the SBRT to the lung, hypofraction to the lung, or conventional dose with 60 grams to the lung tumor.
So is it a central lung tumor or is it peripheral?
Cervical cancer with lung metastasis.
Oh, okay, with lung metastasis.
And we need to treat the lung.
Oh, so okay, gotcha. So I think if you can safely give hypofractionated or SPRT, that's probably preferable to fractionated for 6 weeks. Is that your question?
Yeah.
Okay.
Which is better?
Which is better? I think without any evidence, I can say that we would, in our practice, probably give hypofractionated radiation, like SBRT if you can. If it's too close to critical structures, then sometimes we do like a 10 gray high dose fractionation, like I think like 70 gray in 10 fractions or something like that.
Okay, thanks.
Yeah, but it's hard. You have to be careful because those patients may or may not be curable, and then there's a toxicity of SBRT, so it's, but my preference would be SBRT. So I guess I have some questions too. Is for your patients with metastatic cervical cancer in the first line, are patients getting checkpoint inhibitors if they qualify? So, carbotaxol, Avastin, and pembrolizumab, or just carbotaxol, Avastin, and you reserve pembrolizumab? I'm just curious. Anyone? Do your GYN oncologist give pembrolizumab in the first line setting? Or yeah, no, or no? Some people are saying no. So it's mixed. I would say that sometimes our GYN oncologists, say they want to reserve the pembrolizumab for the next, like if they don't respond to carboplatin, paclitaxel. So it's just interesting with how they've interpreted the data. But it'll be interesting now with the Ruby and the GY018, whether or not we will see less referrals for pelvic radiation for patients with stage 3 disease. So we at Anderson, we radiate patients with pelvic radiation. We give pelvic radiation or pelvic imperiortic for node-positive endometrial cancer. We don't give external beam radiation for like 3A for ovarian, for positive adnexal or serosal disease in the absence of node positive. We'll give the GYN oncologists prefer chemotherapy, maybe brachytherapy, cuff radiation. So it'll be curious for us to see how this will change our practice. We don't know yet. I think we're currently discussing it. So I'm just curious, have you all had any thoughts about, or can you tell me what your practice is for stage 3A uterine cancer? Is it chemotherapy and brachytherapy, or do you give external beam? No? Oh, yeah. Oh, you give sandwich.
Sandwich,
okay.
yeah. Yeah, and the sequence maybe depends on the local factor. If the patient has higher risk of local factor, we will administer chemoradiation concurrent. If the local risk is high, but in our clinical practice, we deliver sandwich chemoradiation. Yeah, chemotherapy is a carboplatin with a paclitaxel followed by radiotherapy. And the further additional three courses, sandwich. Sure. And I also need other audience opinions. But my concerns is about what's the condition we need to vaginal. We also need vaginal brachytherapy. To the pelvic radiation. Yeah, in our institution if the patient have a cervical involvement, we will have additional brachy boost plus to the pelvic radiation based on regional 2018, I remember, the result. Mm-hmm. Thank you.
Yeah, and that's what we do to be honest, like if we give pelvic radiation for uterine or cervical cancer, we will always do a cuff brachytherapy boost sort of reflexively. It doesn't always make sense, but that's what we do. But okay, any other questions? Thank you so much for your attention and the interaction. I'm happy to take questions here.